most of my patients get referred to me, and it's usually larger, more complex stones. So a patient will know that they have stone disease and they'll present to my office on a referral basis. An impacted ureterocalculus is a commonly encountered difficult situation for a urologist. The straightforward ureteral stone is fairly simple, but there are some tips and tricks that you can use to be successful in a case in which you have a well-impacted stone into the ureter. Imaging the ureter is important before you proceed with a retrograde approach. So I usually perform a retrograde pilogram. Usually with that you can tell it's impacted because the contrast will not go proximal to the uterocalculus. And so at that point you know that you've got an impacted situation, and then you've got to figure out how you're going to address it. So usually I'll first try to pass my standard wire. In my practice, my standard go-to wire is the sensor wire, the combination with a hydrophilic tip. I think it's a great go-to wire. But if that's not your standard wire, then I think you first try to pass your regular go-to wire. And after that, if you're having difficulty without pushing the limits too far, you don't want to create a false passage, which is very common in an impacted stone. It's advisable to then convert to a hydrophilic wire, such as a zip wire. You can try to pass that up. Sometimes an angle tip or a straight tip wire to just try to find somewhere around that uterocalculus that the hydrophilic wire will be able to get past. Still, sometimes you're not able to get success with those maneuvers. One thing that I do at that point is I'll bring a open-ended catheter, which I'm usually already have open on the back table. I'll bring that right up to the stone, and I can see that fluoroscopically. And then I usually will mix some lubricating jelly with just a little bit of contrast. So I'll fill that into a 10 ml syringe and inject it right beneath the stone and just lubricate that area and give a little push to the stone. And it sounds silly, but it oftentimes works. And then because you have the contrast that's mixed in with the lubricating jelly, you're able to see under fluoroscopic imaging if the stone is moving, or at least if contrast is getting beyond the impacted stone. So that's one little trick that I use. And sometimes even if I don't see contrast pass beyond the stone, which a lot of times you do, if I follow that then with the same maneuvers I previously trialed with the either telescoping hydrophilic wire through the open-ended catheter or using like a sensor combination wire, sometimes that's enough to just get a little more slippery at the site of impaction to get that wire to pass. One of my go-tos at that point is to use a Segura basket. I think it's a great basket that's underutilized in the ureter. You have to be a little careful with the Segura basket if you're aware it's got a tip, and most people's go-to basket is a zero tip or a nitinol basket, atraumatic with no tip. The Segura does have a tip on the end, and it is a metal basket. It's stainless steel. So you have to be aware, what you're using, and you certainly don't want to create a false passage with that metal tip. But if you can get that up to the stone or even past the stone, what's beautiful about that basket is that it is stainless steel, and therefore it has a greater outward radial force when you open that basket. And so when you open it, it can actually open the walls of the ureter to allow you to then grasp the stone, or at least open it to work at the stone, because a lot of times distal to the stone the ureter will be collapsing in with inflammatory changes. And so I think that's a great use of a basket that people are just not familiar with. And so a lot of times I'll put the Segura basket to the level of the stone, open it, which again, it has beautiful radial outward force. It'll give me a nice visualization of the stone. As surgeons, our biggest fear is complications. And so if you can do anything to eliminate or reduce complications, then that's a huge advantage for us. So initially, we had purely metal baskets, stainless steel baskets, which can grab a stone and then not release a stone. And then you have difficulty in trying to remove a stone fragment that's possibly too big to come down the ureter, and then that can result in ureteral injury, which is the most devastating complication of ureteroscopy is ureteral injury. So the move towards then a nitinol basket, in which, you know, if you have difficulty in removing that stone, you know, you can laser through some of the arms of the basket and free it. You can dearticulate the basket, you can cut the basket, and you can just release the stone without causing injury. I think that's a huge step forward for us in trying to eliminate complications. And then just following that forward, we've seen the end engaging baskets, which I think are phenomenal. The Dakota basket is the one I'm currently using. The end engaging basket is wonderful in that you rarely get a stone trapped in the basket because there is no backside of that basket. When we use, you know, smaller scopes, better equipment, you know, better baskets, that all will coalesce to result in decreased complications and better patient outcomes. I think that you have to know your own limits. I think that's important, just rule of thumb for all physicians, just know your own limits. There's no harm in just placing a stent or coming back another day or asking our IR colleagues to place a nephrostomy tube if there's an obstruction, and just, you know, come back. And I think that's an important thing, to just keep yourself humble, and if need be, come back on another day, a better day.